Welcome to the Health and Wellness Talk Show with Dr. Daniela Steyn. Dr. Steyn is a medical doctor, wellness expert, and assistant clinical professor in family medicine. Her mission is to inspire and enable you to live your best possible life with optimal health. Prevent disease through healthy lifestyle choices and use food as medicine to support longevity, energy, mental clarity, happiness, and well-being. Join us today as she interviews guests, empowering you to live your best life with optimal health. Connect with Dr. Steyn at www.danielasteyn.com. Subscribe to our YouTube channel today.
Good day and welcome. Welcome to today's Health and Wellness Talk Show. I'm Dr. Daniela Steyn, and with me today, I'm so excited to have Gerda with me. So Gerda is known in our community, Oakville, Burlington, the whole Halton, as the physiotherapist. She's a pelvic health physiotherapist with a special interest in menopause.
Yes, that is correct.
And we've done a podcast last year, and we've had, that's one of our most popular podcasts, and everyone has just been sending in questions about menopause, everything about menopause. So I asked Gerda, and thank you so much for joining me today. And we're going to chat specifically about menopause. We'll answer all the questions that you've sent me regarding menopause, and we have so much content to cover today. We're actually going to do this in two parts, where we'll start off with just chatting about menopause. What is menopause? And we found that we get so much education through high school about puberty. Everyone knows what is puberty.
Yes, exactly.
Guys knows what's puberty. Teachers teach puberty. Even if your child does opt out of sex ed at school, you as a parent inform your child about puberty, what to expect, what's happening in your body. We don't have that education with menopause. And a lot of my patients in my specific culture, we talk about menopause. But a lot of cultures of patients that I treat, they don't talk about menopause.
Yeah.
They don't have a mum or an auntie or a best friend to chat about menopause. And I would really like to encourage all of you to surround yourself with amazing women going through the same phase of life as you. I think that's critical, to have that community that you can talk to. But if you need a medical expert, that's why we're here, to really chat about that. And we're going to start off in this first half to really just to go through the basics first, and then we'll go into more details, and then we'll go into things that what can you do to enjoy menopause more, to go through it smoother, to live your optimal life through menopause, to thrive through menopause.
Yes.
So let's start. Gerda, tell me a little bit, just give our audio listeners, viewers, a little bit of a background. Where did you study? What do you do?
Great. Yes. So I am a pelvic health physiotherapist. I graduated in South Africa and was in a sports clinic for about a decade, and really dealing with elite athletes. I was really struck by the fact that ideally we wanted women to act as small men. When things around menstruation were mentioned, when PMS symptoms were mentioned, when performance maybe dropped off when you were menstruating, there was this awkward like, oh, can we just please skip over this? Let's just put you on birth control, and then we can have a set number of days that we can train with you, and then we'll just ignore you for a week, and then you can pop back onto the scene. And
that's true. I've seen that just as an athlete myself. That is true. When people don't understand it, it's just easier not to deal with it.
It's just, let's not go there.
That is true.
And even in research studies, there is not a lot of information on menopause and on female hormones, because how do you get the population size going, and how do you mitigate for the factors of them menstruating at different times? Anyway, so side tangent. So that was me for 10 years. And then I got into women's health physiotherapy out of this sort of niche that I found was missing. We moved to the UK. I had my second son. They were both C-sections. And again, a third of children are born via C-sections. Those are global stats now, especially in Western countries. And yet I had absolutely no rehab after 2 C-sections. And I enjoy running. I'm an athlete, and so
you're going to run a marathon now?
Yes, I am. And I've had these 2 incisions into my abdomen, And so again, I wanted to dive deeper into that. We moved to Canada, and then I heard about prolapse and pessaries because I started working in a perinatal health clinic. And so some more of these complications and side effects and symptoms and just of being a woman, I will say, just became a bit more highlighted to me. And now I am in my early 40s, and the next big thing is menopause. And like Daniela mentioned before, it's underspoken about, it has a lot of myths around it, and it has very negative connotations. And I'm very aware that with the lifespan that women are going to be achieving, that we are going to live arguably half of our life post-menopausally.
Which is very interesting. So for the book that I'm writing, I really researched this, and there's only 4 other animals that go through menopause.
The whale?
Yes. Oh, I forgot
whale?
the other ones.
Yes, I just remember the whale, and I was like, and what I liked about that one specifically, that animal, is she becomes the matriarch then.
Yes.
She leads the pod. And this speaks to so much of the ancient cultures and how they viewed older women as being sources of wisdom, of strength. They were able to meet the needs of the community because they were no longer, fixated on their own family and raising their own children. They had the capacity to be this voice and the spokesperson for their whole tribe. And the wisdom.
And if I look at this, for me, this is the best part of my life, because I don't have that anxieties of the 20s and 30s anymore.
Figuring out what's the
life, being anxious about your kid, how you're going to keep your kid alive, that's done now. And you have all this wisdom that you can share. So it's such, you're at the prime in your career, you're most likely in a leadership position at work, so this is really your prime, but how to thrive through that.
Exactly.
And that's what we're about.
That's what we're doing.
Okay.
Yes.
The next thing is menopause. When do we see menopause? Because that's what often happens to me, is in my clinic, people will come to me and they'll say, I have these symptoms, A, B, C. And I'll ask, could you be menopausal, perimenopausal? And they will say, oh, no, I'm too young for that.
Yes.
Then 6 months later, the same woman will come with symptoms D and E. And I'll say, could it be that it's menopausal? And she'll say, no, I'm too young for menopause. And then only once, 2 years later, when her period stopped, then when we trace back and we say, what did you go through these past 4 years? Yes, it was definitely perimenopausal. It explains why you had it. If we really put our menopause glasses on, we would have managed things easier. You would have had more empathy with your own body.
Yes.
You won't see your body as betraying you by acting different. It's literally because your hormones are different that your body acts different. So what age do we get menopause?
So the mean age, and this is quite interesting, and that is a mean age across all races and ethnicities, is that the mean age is around age 51. Okay, with leeway on either side being 45 to age 55. And so we consider a decade before that as possibly being perimenopause. So early 40s is when women need to start being on the lookout for changes in their cycle, just alterations in mood, maybe in PMS symptoms. We'll get into a lot of the symptoms, but yes, up to a decade before.
And a cycle being more irregular, changes in your cycle. If you had a specific cycle, you might notice changes. If you do notice changes.
Exactly, in length, in volume, in heaviness, in irregularity. That's a big thing. Cycles being shorter, longer, just different. Yeah.
And this now, if you're going through a natural menopause, then we have induced menopause or primary ovarian failure. Can you chat about a little bit induced menopause?
So induced menopause is a more radical form of menopause. It's, like you said, ovarian failure, but it is often also brought on by surgical removal of the ovaries, by chemo or radiation therapy due to cancers, or by medications that we need to use or take to address other disease processes, and then that literally puts you in menopause overnight. So you will still have the symptoms of menopause. Women often report that they come on a lot more quickly and to almost to a greater degree, but they are a bit shorter lived than through natural menopause.
And they can be very heavy. So I've seen with some of my patients, they would say they're going through packs. They can't. I have patients who literally would maybe run their own business and they have to close their business because they're having such heavy periods that they can't function, they can't go to work the way they're losing. Then other reasons which I would see in the hospital and in my clinic where people would go through menopause quicker would be after a significant shock to your body. Say you go through something very traumatic, you lose a loved one, or you have major surgery, even if the surgery wasn't take your ovaries out, but a different type of shock to your body, losing a lot of blood. Cancer and chemotherapy is a big one where we see people going through menopause early. So maybe you were in that perimenopausal phase, but then after you've gone through that operation or that stressful situation in your life, then your period's just gone.
It's accelerated, absolutely. Yeah, and it's a protective function. So arguably they are suggesting that women actually use their cycle as a vital sign. So not just blood pressure and heart rate and all of those issues that we need to measure as women, but also being very aware of what your cycle is doing. It gives us a lot of insight into your health, because when your menses stop, that's a big alarm sign that your body's trying to convey that something is off. So
and we see it in athletes as well, yes, and that's a whole topic on its own, so we won't go into that, but we typically see it in our long distance runners where their period just stopped. And it's a very big alarm sign, because it's not just about not having your period, it's also your bone density, your heart health, everything that you're going to have to deal with 30, 40 years from now that your body is now telling you.
That something's off, yes.
So that's a big thing. So tell me a little bit more about menopause, the detail, the stages it occurs in.
Okay, so we have perimenopause then, that's that decade run-up. It gets accelerated in the 2 years before you actually stop menstruating. And literally menopause, all this hoo-ha is about 1 day. It's literally the anniversary of 12 months without your period. That's it. It signals the end of your fertility, so it's the permanent end of fertility. And then once you have had that anniversary, that birthday of 12 months of no periods, you are postmenopausal. And that's pretty much it.
So that menopause day is really something you see in hindsight.
Yep.
So if someone asks me, oh, please test my hormones, am I perimenopausal, am I postmenopausal? For us, that diagnosis is the last day you had your period, and we say 12 months later, and that is something critical to know, because what you said is that it was the end of your fertility. You can still fall pregnant when you're perimenopausal. And that, so for some people, that can be quite devastating. For some women, it's awesome if you're going through a fertility journey, fertility treatment, you can still fall pregnant, that's great. But then I have so many moms who didn't expect this. You know, they thought they were done, they have teenagers, that they did not. So the fact that you didn't have a period for 6 months does not mean you can't fall pregnant.
No. So you can be then perimenopausal and postpartum, and that's a beautiful mix of hormones for sure. So ladies, contraception. I'm going to come on here and just
we'll do another talk about contraception.
Have condoms around, please. Yes. I mean, if you want to fall pregnant, amazing. But I get a lot of this coming into my clinic. What? Yes. So you are still definitely fertile.
So those are the 3 stages. And then throughout this period, so something we have to say from the get-go, every woman experiences this differently. So in some of the things we tell you, you can say, oh, this is me, but it's going to be different for everyone. So the same as that birth history is different for everyone. You'll have some moms, every mom wants a natural birth with a doula at home. But like you said, a third had to have C-sections. And then the same thing happened with menopause. You'll have those friends that says, oh, I'm just sipping on my green tea and I'm doing my pelvic physio and I'm getting through it. But there are women who has a very, very hard time and they need more help. So first of all, for everyone, the journey is different. And then secondly, so it's not that you're failing if you need help, if you need management. It's just that your journey is different. Your hormones are different. You need different help. Then the stages that we spoke about, for some women it's shorter. Some women really sail through it, and some women have rough seas when they go through it. So the length is different, the symptoms are different, every person is different. And it's because our hormonal fluctuations are different. So tell me about the hormonal fluctuations.
Okay. So we have, first of all, estrogen gets all the attention, okay? And we actually secrete 3 types of estrogen. They have very cool names, but for ease, I'm just going to call them E1, E2, and E3.
Oh, that's smart.
And E2 is estradiol, and E2 is the one that we secrete from our ovaries. That's the magic potion, okay? E3 is the one that we secrete while we are pregnant. It's a weaker form of E2, and then E1, called estrone, is the one that we secrete postmenopausally. So we actually do secrete a form of estrogen when we are postmenopausal. Right. Now E2 works together with progesterone, and E2, we commonly speak of it as a fertilizer hormone. It makes things grow. It keeps our lips juicy and plump. It keeps our vagina happy. It's prolific. It lines our uterine lining. And then progesterone is almost like the lawnmower hormone. It calms things down. Okay.
Oh, I like the way you put it. That's
just fine.
Yes, that's
Because
exactly.
That's what it does.
Exactly. That's
right?
Exactly, yeah.
Okay. So we have a fertilizer and we have a lawnmower hormone. The thing with estrogen is that we typically associate it with our boobs and with our vulvas and vaginas, because those are sort of the classic female sex organs. But every cell in our body has an estrogen receptor, and estrogen is responsible for muscle metabolism. It's responsible for stimulating growth hormone. It manages our blood sugar levels. It's part of our thermoregulation system. It has so many functions, and that is why symptoms can vary so massively from woman to woman and even month to month, okay? Because in the perimenopausal stage, we are getting these fluctuations. And so we might get, relatively speaking, progesterone that's sitting really low, and even though estrogen is coming down, it is still relatively higher than progesterone, and that's when women get these heavy periods. So they are just building lining, fertilizing, and there's no progesterone to come and mow things down, and so you feel like, you know, you're committing a genocide in your bathroom every 6 weeks or whatever it is. So it has this multifaceted implication for your bodily function and systems, and that is why I think symptom tracking can be so tricky, because what are we talking about?
Yes.
Is it, and mood disorders, big thing. That's actually more in the camp of progesterone. Progesterone is seen as I think they call it a brain steroid. It's very calming to the brain, and when progesterone is running low, as it does, you get fuzziness, the brain fog, the memory loss, which is transient. It stops memory function.
And then also migraines and headaches. So that's
Exactly.
often how I manage migraines and headaches, by adding that progesterone
Exactly.
in the second half of cycle.
Especially if you've had it during your fertile years,
Yes.
PMS symptoms with headaches, then progesterone is really helpful.
Something that you can
Yep.
anticipate, yeah. And that is, while you were talking about now, I thought we should acknowledge that I know some of our listeners are transgender, binary, not identifying, and I really try to be respectful and inclusive in that way, but we're specifically talking more, whichever gender you identify with, we're more talking about the uterus and its function of the uterus itself.
Yes.
That being said, interesting, men have estrogen as well, and we have testosterone. We actually have more testosterone than estrogen. So it's normal for all of us to have estrogen, to have testosterone, and we talk about estrogen because we have more estrogen than phenotypically male people.
Yes.
And that's what give us boobs and uteruses and enable us to have babies. However, we still have more testosterone.
Yeah.
While we're talking about estrogen, should we talk why we need estrogen? So just on this topic, estrogen, we need it for bone strength. I'm a hospitalist doctor who see people in hospital who had, for everything. One of the big things we see would be people when they're older, in their 90s, maybe just fall and break a hip. That is significant. If you're in your any age after menopause, if you break your hip, your risk of dying is 30% the year after. You have significant morbidity, mortality from osteoporosis, from breaking a hip. So estrogen is quite critical in maintaining that bone health. This is important. This is not just about what we're talking about hot flushes and about quality of life, which is important to us in the wellness world. But then even if you don't have symptoms, from a wellness perspective, just your bone health, your heart health, your brain health, everything, and we'll get to that. But estrogen is quite important for that. And then typically women after menopause will get that less estrogen content, which significantly impact their bone strength.
Yes, absolutely. So we consider estrogen to be heart protective, brain protective, bone protective, and cancer protective. So it mitigates a lot of the stresses that we place on our body. And so when those levels decrease, we need to do something to ensure that we have continued bone health, breast health, brain health, etc.
Brain health is a big one. That is when I really got into this menopause thing, is my mum believed in her hormone replacement therapy. So she was in a leadership position at work where she had lots of young women under her and men, but she felt to be on the same level, to have the same edge as the younger women. She needed to be on a hormone replacement therapy to be as fast, to be as quick, to be as if she's young, in a high profile job. And then I went through medical school and I read all the studies about hormone replacement therapy not being safe. And I do realize, and we could, if we have time, chat about that, how a lot of things was out of context, how a lot of things, maybe just a very brief touch base on that. The Women Health Initiative in the 1970s, mainstream was, if you do have menopause, let's put you on hormone replacement therapy. Then they wanted to study it. In the 1990s, they had a big study to see, is it good or bad? And they wanted to specifically see, is it going to give you a heart attack? Is it going to give breast cancer? Is it going to stroke? Are you going to die?
Yeah.
But the chance of women in their 50s dying isn't that big. So the way they thought about this study, and we don't do it typically now, but the way they thought about it is, don't test people in their 50s. Let's test people in their 80s and in their 90s. Lots of smokers, like big population was smokers. Let's test them, because the risk of them having something go wrong would be bigger than we know. And they used equine, which is horse estrogen, which we don't use anymore. We use bioidenticals. So it was a little bbit. But then when I saw that research of that study going out, I didn't look at, but this was people in their 80s and 90s. None of them had menopausal symptoms. Very interesting. None of them had menopausal symptoms. However, I just looked through the eyes like, oh my goodness, it's going to cause cancer. My mom should not be on this hormone replacement. She must stop now. But she had all these symptoms. And that's how we got into it. We read everything we could read on herbs, botanicals. In South Africa, we have access to more traditional medicine than a lot of people here in Canada has. So we really went through all the lifestyle things, and to really see, and that's what I've been doing through my whole career, is helping people with lifestyle things, herbs, alternative management ways to how to manage menopause naturally. So there is, and you'll hear through this talk, I'm not pro or against hormones, but I do have all this knowledge, and I'm known as a physician who will help people to manage menopause naturally. So there's this load of things that we can do naturally.
Yeah.
We'll get to it, I think, a little bit later. First, we want to say, why do we want to treat it? We spoke about the brain, or that's why my mom wanted to have hormone replacement therapy, is to be sharp, to be young, to feel young. The other thing is, there's a lot of other symptoms that we use it for, but let's go back to the diagnosis and all the symptoms. So when do you know you have menopause?
So again, retrospectively, it's that 1 year anniversary. So you'll know, oh, right, I haven't had my period for a year. That's when I'm in menopause. And I suggest to women that they start tracking their cycle probably from their early 40s onwards. There's great apps on your phone. You just populate the information in there, and it keeps sort of score, and it helps you sort of jog your memory on what your cycle is doing. So that's one. Symptom-wise, we have weight gain, we have mood fluctuations, we have what else do we have?
And that's why a lot of people come to me specifically because of weight, because that's quite concerning.
Yeah.
If you eat exactly the same amount of things, you do the same amount of exercise, but now suddenly you're gaining weight, and usually the weight gain is in a different pattern. Whereas with younger women, it might be more in your hips and in your bum, and older women, we see it more commonly over the abdomen, where the legs thin out, arms thin out, and the abdomen becomes more round. So the weight gain pattern would be different, your metabolism would be different.
Yeah, and again, that's where knowing what estrogen's function is quite important to figure that out, because it's weight gain, yes, but it's often also changes in body composition. So women will lose lean mass, and they will add fat, and it's that deep visceral fat around the abdomen that Daniela was referring to.
And that's the fat that's harmful for your heart, because that same fat that you can see on the outside also packs around your heart, it packs on your liver, it impairs your liver function. So it's important. It's not about vanity and the look and just embrace your body. It is, but really look at your health. What is this doing to the inside of your body from a doctor's perspective?
Exactly. And so estrogen's function is to be anabolic. It promotes muscle growth. And what used to work in our 20s and 30s and 3 to 4 hour running sessions and gym sessions, who's got time for that now anyway, but this repeated cardio at sort of a lowish intensity, or even weights that you are lifting 25 reps and at a low weight, doesn't stimulate your body to actually generate more muscle tissue. We need to really start loading our system and demanding that via just exposure to really heavy weights, because as estrogen depletes, it's going to stop that muscle conversation to build muscle.
And that's a big thing. I want to pause here a little bit for osteoporosis, to prevent osteoporosis, bone density. And that is something I didn't understand early in my career as a physician, but you have to do weightlifting.
Load.
That's what we call load. Yes, do that type of exercises where your muscle really pull little bit from your bone to help strengthen your bone. That's how you build your bone density. And then also to boost your metabolism, you need more muscle in your body.
Yes.
So if you tell me that you're eating the same, but you're gaining weight, it is really because your metabolism is slower. To get your metabolism up, you need more muscle mass. To get that muscle mass up, you have to do a type of exercise. And it doesn't mean you have to become a bodybuilder, but you have to start doing resistance training with adequate protein in your diet, which is a big part of how we manage menopause. Is really looking at your diet, having protein with every meal, irrespective of which type of diet you follow, to have that protein. Another reason why I'm so adamant about muscle building, if I do get a patient in their 90s who comes to the hospital, was unfortunate, had a fracture, if that patient has strong muscles, the day after the hip operation, they get up and they leave the hospital.
Yes.
If you don't have strong muscles, the next day you can't get out of bed. And if you in your 90s stay in bed for 3 days, it is quite bad, because then you become deconditioned, and the risk of you being for 6 weeks then in hospital, which is very common, is very likely. So if you haven't been up for 3 days, so if you get up the next day, you're going home, no problem. If you've been in 3 days, that because you got so weak from being in bed 3 days, your muscles are going to take so long to recover. With physio, and we have an incredible team at the hospital where I work at. You have your physiotherapist, occupational therapist, everyone, the whole multidisciplinary team who will help you every day to get stronger. But you will likely be with us for 6 weeks in our rehab department before you'll go home. And it's things that you can do now. It doesn't help if you just start doing exercises in your 90s. You have to do it now. When you're perimenopausal, make sure that your muscles are strong for one day.
Exactly. Yes.
So that was all the symptoms we talked about. We have bone health, you have your cardiovascular health. A lot of symptoms people come to me about are vasomotor symptoms. So that would be hot flushes. What is a hot flush?
A hot flush is a period of feeling very warm, sweating.
Very intense. You're like red. People can see it. You don't just feel warm. Everyone around you can see that you're red.
Profuse sweating. And it's due to vasomotor changes. So estrogen is a thermoregulator. It keeps our body temperature nice and level and even as things fluctuate. So the thermoregulation becomes a bit wonky, and your body interprets signals a bit differently or incorrectly. Suddenly thinks you are too hot, and you will feel, and it will try and get rid of that excess heat by opening up the blood vessels on the extremities. And that's the heat, that's the sweating, that's the heat that you feel,
and it's very intense,
the core temperature, etc. So that's a hot flush. And at night they're just called night sweats.
And the night sweats can be significant. Like you can have 10 hot flushes during the day, and the night sweats are so significant that people will be drenched in a sweat. They'll wake up wet and shivering, because now this hot flush is over, so you're all wet. My patients will literally sleep on towels. And I always advise people to layer so that you can take off, but then when this is over, then you're going to be cold again, to cover up. So it's always good to sleep in organic materials, to layer, to have a fan at work, at home. A fan makes a significant difference. So that is quite significant, that vasomotor symptoms. The mood is quite something, and we can talk about that. And typically people go through a trickier phase in life. You have maybe teenagers or people going through empty nest syndrome, or you going maybe through life stages with your partner. So it can be quite troublesome if you now go through a harder phase in life, and now you have your own mood that's up and down. But then if you can take control of your own health, you understand your mood, you track. So important, track your cycle, track your moods. Those apps are amazing to track your moods, so that when you see that, then you don't just feel life is horrible. Then you can also track, oh, okay, you know what, this is my progesterone dropping now. It really empowers you to understand why you're experiencing things.
Absolutely, yeah.
So how do we treat that?
So I would really suggest going to see your healthcare provider.
That's very important. We'll have a disclaimer at the end. It is important to see your doctor.
Yes, absolutely. But so tracking, understanding, but then if you have had a history of depressive symptoms around other big life events, puberty, that PMS period, postpartum, then you are at risk for more severe depressive symptoms, again, around menopause. And so if that is your track record, let's be proactive about it. Let's get on some antidepressants. Let's deal with that. Support groups, I find talking about it and just having a good moan as women without being fixed can be really helpful. And then your diet, we are starting to understand that alcohol, while being a fabulous tool, might not be the best thing.
That's a hard one. It makes your vasomotor symptoms worse as well.
Absolutely. So it's the go-to for a lot of women after a hard day's work, but then often they get clubbed with a really bad hot flash or night sweat at night. And then so your antidepressants, diet, support groups, and exercise. Again, lifting heavy, the high intensity stuff, really great for mood. It does something to your serotonin uptake centers in the brain, and that can really lift mood. So there are a lot of strategies that we can talk about, but antidepressants are definitely one of the strategies that we can rely on.
Something I look at as well always is women's diet when someone comes to me. So 90% of your happy hormone, your serotonin, is made in your gut. Mm-hmm. So it's so important through menopause to look at what you're eating, including prebiotic and probiotic food, sauerkraut, kimchi, really looking at your gut. We call it your microbiome, all those bacteria in your gut, because your gut is full of bacteria, loads and loads of bacteria. And then you can really make yourself happier through what you eat and through your exercise. That being said, I do work in a hospital where we do admit people in our mental health unit with such significant depression that I really want to caution on both sides. So, and you will be somewhere on a spectrum. If you need help, go and get help. See a counselor first, because it is critical to get help first. And then after you've sought help, after you're working with a professional closely, yes, there are things that you can do. Let's do those things. Look at your diet, look at your lifestyle, look at your sleep, look at the alcohol factor. So many things. And that's usually the first thing that people tell me, no, don't take away my alcohol from me.
Yes. Wow.
So, but you'll notice the difference, and it's not forever. It's really just to help your body cope when your body is having a harder time. You want to work with your body. You want to support your body. What can you do to support your body through this phase? Same thing that you're not going to give a teenager alcohol when they go through puberty. You want to support your body. Do everything to support your body.
Yeah.
So we have two groups. We have hormone replacement therapy group, and then we have our non-hormone replacement therapy group. But quite interesting, and I don't want to be known as the doctor doing either of them, because some of my patients come to me and they, oh, you're the doctor who helps women through menopause without hormone replacement therapy. They want to see me as the natural wellness doctor, which I do, but it's because they've been talking to people whose symptoms were very well treated without medication. And then there are women who come to me and they're like, oh, you're the miracle worker with menopause. and they want A, B, and C prescribed, which their friend had. But we look at everyone, every person needs something else. We really have to look at you, your body, your medical history. And that's when we start with intake. You as well take this history when someone comes to you. We need this whole history where we really find out what's your genetic risk, your own risk, your heart health, what does your cholesterol look like, your blood pressure, do you have insulin resistance? We look at the whole picture. Then we look at all your symptoms. We look at your goals. Because even with symptoms, different people have different goals. Some people have hot flashes and they're wet all over, and everyone in the boardroom can see they're wet because I'm going through menopause. It is what it is. But to some women, do not want anyone to know. So it's also, what are your goals with your management?
Yes.
Okay, so will you explain the options, the hormone replacement?
So hormone replacement therapy, we have estrogen therapy that you can get if you no longer have a uterus. It's a big thing. Remember the fertilizer kind of analogy?
Yes, because if we do give estrogen, when you go through menopause, we're making the estrogen thicker, and that is when you'll see that estrogen increases your risk of uterine cancer. If we do give estrogen, we'll give progesterone with it to protect your uterus.
Exactly. So combination therapy, and the most efficacy we have found is to actually start it as close to menopause as possible. Cool. So we have about a 5 to 10 year window, arguably, so it's sort of 50 to 60 maybe. Beyond that, the risks start outweighing the benefits. So if you are wanting hormone therapy, let's start that conversation earlier rather than later to really boost the benefits of it while avoiding the risks. So that's the one arm. And then non-pharmacological interventions, again, are that sort of holistic lifestyle approach. And then one thing we haven't chatted about is adaptogens, which are plants. It's a big thing coming
make a
through.
Lot of quality, improve your quality of life, yes.
And so adaptogens are plants that are able to mitigate the stress response in our body, and they have an effect on our autonomic nervous system, and they impact cortisol production and cortisol absorption, and cortisol is your big stress hormone, okay? And so adaptogens can either be calming or they can be stimulating, depending on whether or not you are just running on empty and it's go, so you need something to calm, or if you have very low mood, a lot of depressive symptoms, then we want something that
boosts you that bit,
gives you stimulating. So they have great names. One of them is holy basil, and I just think, who wouldn't want some holy basil in their diet? It's beautiful. And the other ones all sound Indian to me, and I cannot pronounce them properly. There we go.
It's a very good one, yes. And then, but
Black
that's
cohosh.
Yes. These are the easier ones. That's
yes, I've got a book. But anyway, adaptogens.
And it also depends on your symptoms. You'll talk to your care provider, because for different symptoms, there's so many different symptoms. If it's specifically sleep, you'll use valerian root. Through menopause, your body secretes less melatonin, which naturally helps you to sleep. So you'll take a melatonin supplement. So it really depends on your supplements, and these are all great. It can make a significant difference of life, but you're not going to just go to the pharmacy and buy the whole whack load. You're going to specifically use ones that your body needs.
And so for HRT, just one last thought is that we have systemic HRT, so we can take them in pill form orally, and that is really for the global symptoms of menopause. So if there's maybe an osteopenia risk that we've identified, we would want systemic estrogen and progesterone. And then if there are more symptoms around vaginal discomfort, and
that's a big one. We must talk a bit more about that.
So they've identified something called, it's a syndrome by the name of genitourinary syndrome of menopause. Sexy, it's great. I don't like the word syndrome because it implies that if you have to have all the symptoms to make that applicable, and again, women differ. So you have certain features that impact your pelvic health around menopause. You are more likely to have stress urinary incontinence, urgency, frequency. Urinary tract infections is a big one. It's not actually bacterial overgrowth in the bladder. It is a pH change in your vagina, which makes you more susceptible to any bugs, just acting and irritating the urethra, because again, estrogen lines the bladder and the urethra. So you have these symptoms around menopause, and if you have those, then you'll want a local estrogen cream, gel, an insert. It's a pessary or an e-string, something that actually just secretes estrogen. So yes, so again, what are your symptoms? Are we talking systemic or are we talking local? And then we can make the correct...
Yes, because you won't use, if your only symptom was more often bladder infection, you don't need systemic treatment, you really just need... And that is one thing. So we said the benefit is just that first 5 to 10 years after menopause, and we only treat that. However, in hospital, I treat people every day who are in their 90s with this vaginal estrogen.
Yes.
Because what happens if you did not have your HRT in your 50s, 60s, that vaginal skin will be very thin by your 90s. And then you more commonly get a bladder infection. If you get a bladder infection, when you're frail otherwise, you're at a very high risk of that infection spreading through your whole body. We call that sepsis. So bladder infection is not that bad when you're 20, 30 years old. You can take cranberry juice. If it got very bad, you can maybe take 3 days of antibiotics and you're good. But when you're older, that can spread to your whole body. And I admit people to ICU with that, with urinary sepsis. So it can make you very sick. And that's why I have this disclaimer, whatever I tell you, don't just go and buy the herbs, go and see your doctor first. Please. But when your doctor say you're good, then you can come back and get all the herbs that I tell you about. So I admit people with urinary sepsis. If we do admit people with urinary sepsis, it can be life-threatening, it can make you very ill, your morbidity, mortality is very high. For those people, we would, even if you're in your 90s, give you your estrogen, different ones, either cream, if it's tricky to insert a cream at that phase, we can give it's like a little vaginal tablet that we insert initially every day. As the vaginal skin gets a little bit thicker, 3 times a week. When it's nice and thick and plump, then we can do weekly to keep it thick, to prevent infections.
Yes.
So that's still definitely something we do. So that's a vagina. Next thing about, you know what you have to quickly talk about, please, is specifically urinary incontinence. That is one of the big things. I do triathlon. I went to World Championships this year. It was a big deal. I did the Ironman Muskoka. It was a big deal. One of the most amazing athletes she's much better than me. She trained more than me. We're just writing a menopause book about her. She gave permission that I can talk about her. She's really amazing. She came to me, and she's just a friend. We trained together. She came to me and she said, I have to help her. She can't run without peeing her pants. And that's her thing. None of the other menopausal symptoms, she could breeze through everything else, but she can't run without peeing her pants. And I've had athletes who tell me that. I'll refer to pelvic physio first thing. And I would say, just have a little bit of a pad in your running shorts to help leaking urine. But with triathlon, you have a specific triathlon suit in where you first swim. So you can't swim with a pad. Your pad is just going to soak up for 4 years. So first she's going to swim, then ride a bike, and then she's going to run. So there's no way you can have a little bit of a pad. So that was a big deal. And we managed to help her very successfully. She's eternally grateful. To any of our audience today, just chat a bit about...
Okay, so your pelvic floor is a muscle and connective tissue working in tandem to support your bladder, your vagina and uterus in the middle, and your rectum at the back. Okay, so we need to consider both in the equation. We need to look at muscular function. What is the strength? What is the endurance? And again, remember, postmenopausally, our muscular tissue decreases in size, in strength, in capacity. Okay, so we have muscular changes that might be happening. And then connective tissue, collagen, ladies, we all know, the wrinkles, etc. What's happening on your face when you are laughing and smiling and shouting at your children is probably also happening in your vagina. So we just see connective tissue changes happening and less support through this connective tissue. Then we need to consider, what was the birth history like? Was there forceps use? Was there an episiotomy? How many children are we talking? Is there any prolapse? So is the vaginal tissue not adequately supporting the bladder to the front, the rectum to the back, or even the uterus to the top. And so it's a look, let's look at all these factors. Yes, Kegels, so let's strengthen those muscles, let's make them more responsive, let's bulk them up, let's make their quick firing capacity, let's improve that. But then also, let's look at the connective tissue, and hyaluronic acid is a great moisturizer. It's in a lot of high-end face creams. So I say these lips, those lips, let's get them all moisturized, and that can improve connective tissue function. And if we need to go that extra mile, let's put some estrogen locally into that area too. So it's a combination approach, but for the most part, women 90-95% improvement. If the urethra is unstable, we can use a pessary, which is a small intravaginal device that you insert into the vagina. It's like a tampon, and that literally stabilizes the urethra. And so with running and impact sports, we no longer get that urine leakage through the vagina, through
Yes,
the
you
urethra.
you explained it very well. Yeah, thanks. So we covered now. Did we cover sleep? Let's chat about sleep a little bit. Because sleep is a big thing, because your body secretes less melatonin.
We get the hot flashes.
Which wakes you up. Night
Yes.
switch, which wakes you up. So you're now awake with getting this adrenaline rush through your body. You know, that is quite significant. It impacts your mood if you're not sleeping well.
Exactly.
It exacerbates brain fog the next day.
And then we have, just to, throw in some fun into our mid-40s, sleep apnea. Big thing that can start developing is just that sort of you missing a few.
I want to talk about that.
Okay, I'm going to hand that over to you because...
No, but you can first finish, but I just wanted to say this is something we often miss, sleep apnea.
So I'll let you...
Okay, talk about that after.
Yes.
Okay.
So sleep apnea, then we can just have chronic illnesses that are catching up with us through the decades. Diabetes, restless legs is a big problem, and that to me is always an indication of a lack in magnesium. And so I'm a big proponent of magnesium just because it makes you have a poo the next day, and I'm all about poo. Let's have the poo. So restless legs, sleep apnea, and then I'm going to hand over to
about
you
the sleep apnea.
Yes.
We often miss that, and I really, looking back, I think I might have missed it earlier in my career as a physician as well. We see it in men all the time. We know that men have sleep apnea because their wives come in and tell us they have sleep apnea.
Yes.
So what would happen with sleep apnea, you go through periods during the night where you stop breathing. There's different reasons, and in men we typically see it when they're overweight and there's a little bit of extra fat lying here, that it almost a little bit smothers you when you at night you're lying on your back and everything is relaxed, and then you go through this period where you don't breathe, and then your oxygen levels drop. Because your oxygen levels drop, it sends a message to your brain to wake you up. And then as soon as you wake, all your muscles are more tight again, and then you're breathing easily again. And then when you fall asleep and you go into your deep sleep, you go through that phase again where you're not getting enough oxygen to the brain, and it wakes you up. So you might not notice it because you're from a very deep sleep to a very superficial sleep to a very deep sleep. So you might not know it. Your partner might notice that they can hear you stop breathing, and then you're breathing again. And then we diagnose it with sleep testing. We have monitors on which monitors your oxygen. To women, this happens even if you're not overweight because of your hormonal changes. And they might not recognize it. You might just be tired the next day, ridiculously tired. Because you're tired, your body is now going to need more food. So you'll have cravings because you need sugar for energy because you didn't get proper rest last night. So you're going to eat more unhealthy carbs, you're going to eat more sugar, you're going to gain weight, you're going to have tiredness, brain fog, irritableness, anxiety, depression. So quite often we see those hormones, and if we just do a sleep study, get proper sleep.
Yes.
So sleep is a big thing.
Yes.
You need to be, we're looking at everything, but we always look at sleep, no matter what illness.
And we're starting to now understand that sleep is one of the key drivers in preventing diabetes. It's when your body regenerates and heals itself. So if we are not getting those REM moments of like deep restorative sleep, we are just shortchanging our body and driving cortisol up. And that's your, like Daniela said, that's your stress hormone. And then you can be eating, honestly, lettuce leaves and a bit of hummus. that is going to pack on fat because your body is in a state of
Stress.
depletion, and it perceives that as threatening, and so it's going to hold onto your fat stores. And then we're in a vicious cycle. We eat less and less and less, especially protein. And so, yes, so sleep, my colleague, that's her big thing. She starts everyone on sleep. Like, track, we have watches, most of us, that can track that, and that's a great way to just understand what is your physiology doing at night.
Yeah.
How much restoration are you actually getting, if any?
That's big, yes. And we've had podcasts on sleep. Maybe I should have her as well.
Yeah.
I just recently, we released a teenager podcast on sleep, but we should maybe do a menopause on sleep because it's such a big thing.
Yeah, absolutely. Okay.
So, and then exercise. Chat about a bit exercise. You're a big exercise
Yes.
guru, sports physiotherapist. You're going to run a marathon now in a bit.
Yes, so I'm the cardio queen. I love a good run. I leave the kids at home and I just head out, put on my shoes, and I go. And I love it. But it is no longer serving me. I'm starting to understand that. One of the big things also that estrogen plays a role in is actually in inflammation regulation. So as our estrogen decreases, we are more likely to be in a state of inflammation. So a lot of women will come in, that was in my sports physio days, and just say, I'm starting to get arthritis. Shoulders, knees, hands, and so we would put them on the arthritis kind of track in that direction. A lot of joint support, glucosamine, blah, blah, blah. And now that I'm understanding what is actually happening in the woman's body, I'm like, oh, it's inflammation. And so exercise then is a great way to get rid of that inflammation. If it is in more sort of shorter bursts of high intensity, just running excessively just builds lactate, and then we're just augmenting that inflammation. So the recommendations now for menopausal health, to really get the benefits of exercise, let's do short intensity, high intensity stuff. So even like 8 seconds, they did a study, they put 60-year-olds into placebo, into groups. And they had one do 40 minutes of cardio twice a week, and then they had another group do 2 sessions of high intensity stuff. So it was literally on a stationary bike, 8 seconds on for as hard as they could pedal, 12 seconds off. And they did that for 20 minutes. And they compared these 2 groups, and they found after 8 weeks, both groups had increased fitness in fitness, but the high intensity group had increased their lean muscle, and they'd significantly reduced their abdominal fat. And that's where the magic happens.
And it increases your metabolism for a couple of hours after.
Exactly. So the high intensity stuff, and it fits our lifestyle. Like, if I need to do 30 minutes a day of high intensity stuff, that is much easier to fit in my day than an hour and a half of running, which is not, I'm just spinning my wheels essentially. So high intensity stuff, yoga, we need to move, we need to stretch, we need to work on our balance as we get older. And yoga sort of hits a lot of that brief, as well as being very restorative. It often elicits a deep relaxation response, and we are, generally speaking, we're on the go women, and so we are often more in that high sympathetic state, a lot of go, fight or flight. And so if we can swing the pendulum back to being in the parasympathetic and achieve that deeper relaxation, our cortisol goes down, and that sets us up for better sleep often. So high intensity yoga for mobility, balance, and for deeper relaxation, and then lifting, heavy lifting. And that's really, we need to be at 3 to 4, maybe 5 reps of as heavy as we can go. Forget the 5 kilogram stuff, that's not going to cut it. We need to lift heavy. And make it short, make it meaningful, make it matter, and then have real off days, have rest days, because our body is going to take a while longer now to bounce back, and if we give it the rest it deserves, the next day we can come back and be strong and get our goals. Yes.
And then we spoke about stimulating your parasympathetic system. This is a big thing in menopause. So we want to stimulate our parasympathetic system to sleep better, to be more intentional at work, at home, practice mindfulness, and I have a whole blog and another video on breathing exercises. That's the easiest way to trigger that. You have a vagus nerve all the way from the back of your head. It goes past your diaphragm and then all the way down, all your muscles. So if you're in fight or flight mode, to counter that, best is to do deep breathing exercises. Then you stimulate your vagus nerve. Then you stimulate your parasympathetic system. You lower your heart rate and you lower your blood pressure. That's incredible. You can do it. You can just test yourself. You can look at your heart rate, do deep breathing, and you can like physically lower your own heart rate. It's completely within your power. And then as you continue to practice this and get good at it, it can be a game changer during hot flashes.
Yes.
If you get those, some people get this really anger bursts, which is a hormonal anger burst, but makes you angry. If you recognize that and you're just breathing through it, there is a lot of research showing that it improves your vasomotor symptoms. And it's something you have the power over. You don't have to pay for it. It's something you can do. You can empower yourself. You can take control of your own body.
Yeah.
Getting your vagus nerve, practicing breathing exercises when that hot flash comes on. If you practice breathing, you can decrease the intensity as well as the duration of that hot flash.
You've jogged my memory. Hot flashes. 2019, the North American Menopause Society released a finding that if the severity of your hot flashes and the duration of them can be an indicator of cardiovascular events later in life. Okay, so we're talking about vasomotor, so it makes sense. Estrogen has an impact on how flexible our arteries are, so they tend to stiffen up as estrogen declines, which makes blood flow through our system a bit more difficult, which is why our blood pressure rises. So if we're having a lot of vasomotor symptoms during menopause, it's a communication that, hang on, that whole blood system, the blood flow is not working optimally. And having an ECG, checking in with your GP, so just important. Having a scan around heart health can be arguably life-saving.
Yeah, it is. Yes, no, that's a very good study and important, that really stress why you have to keep track of your menopause symptoms. Why getting help for menopause does not mean that you're weak. The fact that your sister and your mom could sail through menopause without having help, the fact that you are getting help, maybe you are preventing cardiovascular disease for you later in life. So that is important.
Or that fracture, that hip fracture at 95.
Yes.
So
you're going to exercise, sleep well, eat well. Eating is critical. Then you're going to make sure that you join a support group. Surround yourself with other women who's going through menopause, who has gone through menopause, who you can share your journey with. If you really can't find anyone, go and look for an online support group. We have an online support group that we're running that has access to a nutritionist, dietitian. If you just want to ask a question, you want to say, you know what, I ate spicy food and my hot flashes was horrendous after. And then people can say, yes, there's science behind it. Don't eat spicy foods. Or go through that. So to kind of help you with that support, talk to other women who go through things, see what other people do. Say, oh, I have this hot flash, this little fan, like with a clip, on my computer screen, things like that. Other people can tell you that's going through the same. So find yourself a supportive group, a community, a tribe. Find it. It's important.
Yeah.
Then there's some over-the-counter things you can buy.
Yes, so over-the-counter medication is going to be, from a physio point of view, the topical hyaluronic creams for skin, because that's another complaint in menopause and post-menopause, is this aging skin, this drying skin. So over-the-counter, often we have chats about that, about a good quality moisturizer. Toner. I always skip toner when I would get the wash, and then I would just go moisturizer, and toner actually rebalances your pH before you put the moisturizer on. I was like, who knew? So toner, great as we get older to just add that in. Again, we want that pH to be as close to normal as possible. The hyaluronic acids, the vaginal creams. Please stay away though from powders and soaps and scented products.
Anything with a scent.
And pads. I hear you're leaking, but maybe Nick's underwear, the the leak-proof underwear seems to be a better option
good.
because your pads have a lot of what makes them white is bleach. Sorry to tell you, and bleach and your vagina just doesn't sound good together in a sentence. So let's keep away from that, or go for the organic cotton products. They're a bit more expensive, but your vagina will thank you for all eternity.
And I've had people with significant allergic reactions, like dermatitis of the vagina because of white pads.
I had them because of tampons. Now you know that about me. I was like, no menstrual cups for me, silicone all the way. So like, even and talking about this and knowing that this is a thing that women experience, like, I think we just need to
everyone don't have to experience a vaginal rush themselves before. You can just hear from your friends and avoid those products.
Exactly.
I have an app on my phone. It's called a Yuka app, Y-U-K-A, and I'm so impressed with it. I tell everyone about it. You can scan your products when you go into the pharmacy. You can scan and it shows you if your product's safe or not, and your food. They don't scan your pantry. It's quite stressful to do everything in your pantry. That's not healthy.
No.
But when you go grocery shopping, before you buy, now with school snacks for kids, I would scan it and it looks healthy because it's all organic and but then it shows you it's full of sugar. Don't buy it. And then it also shows you similar products that are, okay, so you are looking for a granola bar, you are looking for something organic. These ones have less sugar, less processed things. These are healthy. So it's a very good app, the Yuka app, Y-U-K-A, very good. It's a free app. Then something else when you are buying feminine products is lubrication. So you're likely at your sexual peak. You don't have your body issues that you had anymore when you were younger. You're at a more mature stage. You're hopefully in a very good relationship. So you can really enjoy sex in a way that's really at your peak. But your body's not naturally secreting that lubrication anymore that it used to secrete. So you'll have to buy over-the-counter lubrication to help. That's important. If sex is painful, see your doctor. It can be a red flag sign. So you'll need longer foreplay, you will need more lubrication, but make sure if it's painful that you see your doctor and have an exam done. That's quite important.
Yeah. So that's another thing that ties in with that is libido. Lower libido, is that a sign of menopause? And I say it's common, but I don't want it to be a sign or symptom, because I think libido has so many components to it. We have the internal state of what's happening and our external circumstances, and that equation brings us closer to that libido point. But like Daniela said, if pain is a problem, then absolutely seek help. Women do not need to lie back and think of England and it feels like they're being cut open. Not cool. No.
Did you know that's where the word vagina comes from? It's like the word vagina means it's the sheath of a sword. That's weird, don't you think, that a body part gets...
No, in German, it is still the sheath of a sword.
Oh, seriously?
That's Scheides, the German word, and it's the same word for a sheath of a sword, yes. Great. I grew up German, so that's very
interesting. And then there's an Indian word that some of my patients use, uni, yes, which is a more beautiful name for a vagina. But whatever you call it, and make sure
yes, that it's healthy, and that if it's painful, you need come and see me. We'll sort it out.
Thank you so much for your time, and I know our listeners gain so much from this.
Are we going off tangent? Yeah. Talking about sex now.
And I have such a thick pile of questions that I'm going to ask you, so I think we'll put that to our second, because this is kind of a two-part series.
Yes, I think we're.
So we'll do that on the second part and answer. And thank you so much for all the questions you've sent in. And you know what, we did cover quite a big bulk of all the questions, but we might as well, I'll go through the questions because I really want to know if you've gone through the trouble and you've sent in a question, it's something that's important to you, that we do answer that. So we'll come back in the second half and then we'll go through your questions one by one and answer it. And I really hope that we can help a lot, you know, that a lot of you, that even if you're not the person sending in the question, maybe you had the same question, hopefully we could have answered that. If you want to reach Gerda, down below I'll have your Insta and your website address so that people can reach out directly to you.
Thank you.
Good. You
look back and you realize, oh, hang on, I haven't had a period in 12 months. that day, that anniversary of the last menstrual period 12 months ago is the day you reach menopause. So it's a big topic and a big word for literally one day in your life, and then after that you are postmenopausal.
But everything we're talking about, the big topic, is not really for that one day, it's the perimenopausal phase.
Absolutely.
So that's our heading, is that really perimenopause. We're still talking menopause. We've done this whole 1 hour chat about menopause, going through what is menopause, covering all the basics, really wanting to help you, equip you, empower you to take care of your own body, really to own your own health, to thrive through menopause. We want you to live with optimal health through menopause. We're passionate about menopause.
Yes.
I'm a medical doctor with a special interest in menopause, in lifestyle medicine, in women's health, in nutrition. And Gerda is a pelvic physiotherapist with a special interest in menopause. And she's really an expert in our area, where all of us refer our patients to Gerda. That's why I really wanted Gerda to come and chat to you today. I have a thick pile of questions that you sent me asking Gerda to answer this. And we did cover a lot of these things with our chat about menopause. I am going to go through these questions though, just to make sure that we didn't miss anyone. Will you just, in a summary, say what is menopause?
Okay, thanks Daniela. Thank you for your introduction. So menopause is literally a day in time, and it signifies the permanent end of fertility. It's a natural event. I really want to highlight that it is going to happen to every woman on this planet. The mean age of that occurring is age 51, with sort of a swing number between ages 45 and 55. Ask your mum or any other female relative in your family when they underwent menopause. That will give you a pretty good idea of when you are likely to reach menopause. And
the concern just with that, I find, is without toxic exposure,
it's
to this
earlier.
Yes, unfortunately. So we are exposed to a lot of toxins, pesticides, plastic products that we use in our beauty products. There are these, we call them xenoestrogens. It's products that mimic estrogen.
Yes.
And it confuses your body, because your body thinks that it's real estrogen. I have to secrete less estrogen because I'm getting this estrogen in. It has a whole, and that's quite a whole topic on its own. I have an ebook that you can have a look on my website that you can download. It's a free ebook, how to balance your hormones naturally. But it really talks, if you want to balance your hormones, you must look at that exogenous estrogen exposure. And some estrogen we know about that we get from cows that are given estrogen, or that we get from cow milk. We know about those things, but then there are a lot of pesticides and chemicals that can cause it. That's why we see puberty so much younger and menopause earlier. And all of them affect our fertility.
Absolutely, yes. And so menopause is a reflection of a reduced function of estrogen. And we typically start transitioning into the perimenopausal phase about a decade earlier. So in your early 40s, and that's just, again, you have a finite amount of eggs, and they are decreasing in number, and as you transition into perimenopause, you might not be releasing an egg with each cycle. And so that is what this whole peri and menopausal phase is all about.
And then we can also see at the end that what we were saying is you might still fall pregnant at the end, even though your menstrual cycle is irregular. So to always be conscious of that, consider a form of contraception or condoms when you're getting to the end if you do not desire fertility anymore. There's so many myths around menopause. So let's dig into them.
Let's do it.
And then also what we have to stress about the age, you said the mean age is 51, but it means that a big portion of you, because everything kind of on a bell curve, the mean age is at 51, but some of you will be going through it at 40, some might be going through it at 60, and you might not recognize it at 40 when you go through all these symptoms. You might not understand it. So we are here to help you, to empower you, to explain to you, this is menopause. When you experience these things, this is what it is.
Yes.
So this is your natural menopause. Then there's something like induced menopause. What is induced? If I, as a doctor, cause menopause on someone, what's that?
Okay, that's a much more radical onset of menopause. It can be due to surgical removal of your ovaries in particular. If you just have surgical removal of your uterus, you will stop menstruating, but the ovaries will still be secreting estrogen. So that can be a cause for induced menopause. Then we have radiation and chemotherapy, either to local tissue or just in general to the body. It takes a big toll on the body, and so that can stop menses, so it can induce menopause. And then we also have not over the counter, but medically induced menopause if we are taking certain medications to treat other disease processes, and that can also induce menopause.
Earlier, and then when someone goes through significant stress, loss of a loved one, something significant, you might go through menopause, something that's a very big. I've seen that in patients refugee patients that I have now, that if they'll tell me, my mum was like 5 or 7 years older when she went through menopause, but just coming to Canada, going through this whole process, their body just said, I can't have a baby now and deal with what I just had to deal with this past 2 years, and it just stops. And it's menopause. And we know now that it's menopause because the period didn't come back. If you go through that stressful period, you might have it for 3 or 6 months, not a period. But if your period didn't come back, we can look back and say, okay, you're definitely in menopause now because your period didn't come back. Okay. So, and we kind of chatted about like when natural menopause occur, and I always am so careful to use the word natural. I do realize things might be different for different people, and we're cognizant of our patients and audience who doesn't identify with specific genders. So even when we talk about women now, we are talking about a phenotype. If you do have that uterus, if you do go through these hormonal fluctuations at now. So what happens in your body during menopause? Why do we go through it? Because what we said is most animals, there's only 4 species of animals that does go through menopause. Why do women go through menopause? What happens? What causes menopause?
So like I said, we have a finite amount of eggs in our uterus, in our ovaries, and we secrete an egg every month, which is what starts puberty, and then that egg gets released into the uterus, and we get the thickening of the uterine wall in preparation for implantation. If that doesn't happen, your body figures out, hang on, there's no baby here. It secretes progesterone, and that sheds the lining, and that is what's known as your period, so the bleeding. And we have this cycle repeated month after month for our fertile years, and then we start sort of declining our egg stock, and that is when we start transitioning into the perimenopausal state. So we might find that on certain months we don't have an egg released. We find that there are fluctuations in hormones. It's part of an aging process. So it has to do with our fertility and our eggs, but also with just hormones and how they relate to each other, what levels they are, and how these fluctuating levels are perceived by the body and the symptoms that come.
And how your body responds to it. And we'll go deeper into the symptoms that you experience. And everyone experiences it differently. For some people, it's more abrupt stuff. For some people, it is very, if you just think how you went through puberty. For some people, their hormones were all over the place. Some people went very smoothly through puberty. And the same happens with menopause, that everyone experiences it differently.
Yes.
So how is menopause diagnosed?
Retrospectively, it's if you look back and you realize, oh, hang on, I haven't had a period in 12 months. That day, that anniversary of the last menstrual period 12 months ago is the day you reach menopause. So it's a big topic and a big word for literally one day in your life, and then after that you are postmenopausal.
But everything we're talking about, the big topic, is not really for that one day. It's the perimenopausal phase.
Absolutely.
So that's our heading, is like perimenopause. So a lot of people come and see me in my family practice and they ask, can I just test their hormones? Because they feel they're off. And I've always found that very tricky as a family physician, because if I am to test your hormones during your perimenopausal phase, say we do blood work, our general covered by Ontario Health, government paid blood work, that just test for certain things, your levels might look perfectly normal. And it's very likely just because your levels fluctuate to such a degree that I might send your blood. And it's still important to see your doctor because there's many other things that happen at the time. You're at a higher risk for diabetes, your doctor will test for that. You're at a higher risk of getting higher cholesterol, your doctor will test for that. Your thyroid can be off. With the hormonal fluctuations, we often see that your thyroid will be off, your doctor will test for that. But I find it frustrating when someone knows, my patients find it frustrating when they know something is off. They want me to diagnose, to say whether they're perimenopausal. But because of this fluctuation, if I do your blood work today and tomorrow and the day after, the values might look different. And that doesn't give you the answer you want. So you don't have to do any blood work tests to diagnose menopause. We don't diagnose menopause by a blood test, we diagnose it by symptoms. That being said, there are testing available now. It's not your mainstream paid for by government testing, but there's amazing testing that when patients come to me, I always say, oh, you don't have to test. But if they say, but I want to know, I want to test, we do have this testing available where you can look at your levels and we test over a couple of days, or look at urine over a couple of days where we can send dry urine samples away, where we look at your estrogen, progesterone levels, how it fluctuates, where we get a much clearer picture what happened over the course of a month. And you can repeat that again at 6 months, at a year, we can trace much better and see, you know what, your estrogen is a little bit low, your estradiol is a little bit low, your progesterone a little bit, to tailor. But if you're listening now and you don't have access to testing, we don't have to test. It's really something that goes retrospectively, the diagnosis, but our management not. And we manage symptoms. So, and we'll delve into that later, but we're going to treat symptoms. We don't have to treat menopause. Menopause is not a disease.
Yes.
It's something natural that you go through. It's something that we have to celebrate, because that really signifies that you're now going into this next phase of life where you're really more mature, you have more wisdom, you're a leader in your community, you're a leader in your family structure. It's something that we want to celebrate. We are here to guide you through it so that you can celebrate it, that it's not as hard. And we're going to treat symptoms. So if your symptoms are your vasomotor symptoms like hot flushes, you're going to treat that. If your symptoms are dry vagina, we're going to treat that. But we don't treat menopause, we treat your symptoms.
Absolutely. And just as a sidebar, a lot of healthcare professionals actually really appreciate if you have done some tracking of yourself or of your own. So there are great apps that allow you to track your menstruation, but also just premenstrual, PMS symptoms. So what is your mood doing? What do you find that you've got more bloating, more breast tenderness? What is your mood like? Your sleep, your anxiety? Really track those. They can often be a great tool to enter into discussion about tailoring whatever we use to really fit your profile, rather than just broadly speaking, I feel I'm murderous all the time. Let's get some frequency, let's get some intensity down on paper, so about 6 months worth, and that can really open up the conversation in a way that we can make it more tailor-made to your needs.
That helps. That is critical, because if someone comes to me and say they want to be treated for menopause, we don't have a treatment for menopause or perimenopausal symptom, but we're going to treat your symptoms. We're going to help you. What do you need? Every person that I've ever had through my clinic, their treatment is different. Every patient that you've ever had, treatment is different. It is so person specific how you experience it. So what are the symptoms that our audience can anticipate if they go through menopause? What must they look out for? Because that is something big. People sometimes come in with a symptom and I'll ask, could you be menopausal? And they'll say, oh no, I'm too young. So what must they look out for?
So the two cardinal signs that we equate with this transition is hot flashes, night sweats, and definitely vaginal dryness. That's a discussion often in my clinic.
That's from a pelvic physiotherapist perspective.
Yes. So we get hot flashes and night sweats. That's this sense of like overwhelming heat building up in your body. You are flushed. Everyone is aware of you having a hot flash, excessive sweating, especially at night. We have weight gain, and arguably that's more a change in body composition with loss of lean muscle and gaining of fat, especially around the abdomen. So a lot of women complain of that. Mood changes, anxiety, depression, an altered resilience to stress. So they feel more overwhelmed by life, by stress. And then we also have some changes around function, just stress urinary incontinence. Again, that's in my practice, but cardiovascular function. They feel they are more out of breath. They can't exert themselves to the same degree. And so, yes, a whole myriad of functions, and it all pulls back to what estrogen actually does in your body. And so once we understand estrogen's function, we can sort of start putting things together when it doesn't work optimally anymore, how that presents in the human body.
And I didn't want to interrupt you, but what you were saying about the mood. So one of my patients, because I always ask, what age did your mom go through menopause? What was your mom's symptoms? And she says what she remembers about her mom would just cry all the time. That was honestly, she and her mom didn't talk about, like my mom told me everything about her menopause. We knew too much because we would like try to find all the herbs and natural remedies for menopausal symptoms. Her mom didn't talk about anything, but she just recalls her mom was crying all the time. And then later her mom was not that cheerful, and earlier in life her mom was not cheerful, but that's her recollection, you know. So if you do find that you're just crying all the time, you don't have to suffer through it. There is help. And we spoke about that earlier, but while I'm on the topic as well, if you have significant mood symptoms, go and see your doctor, go and see a counselor. It's critical. It's nothing something you have to suffer through. Even if you say, okay, this is just menopausal, I just need this treatment or medication or help now, still get it for this 2 years. And then afterwards, if you don't have your symptoms anymore, you can stop it. You don't have to be on your medication for life. You're going to use it while you need it. So we have the vasomotor symptoms, the effect on our cardiac health, risk for diabetes, and then our mental health symptoms. Those are typically why we would see people having painful sex or discomfort with sex, vaginal dryness, bladder infection. That's most commonly why we in the health world see people regarding menopause. Then people want treatment. So some people come to us saying that I please want some natural management. I don't want hormones. Yes, we can definitely help you. That's what we do in holistic healthcare. We help people. And then for me as a doctor, a lot of people want hormone replacement therapy. So these are our options. And we did talk about that, but the specific question here is, do you have to use hormone replacement therapy?
Okay. Loaded question. No, the answer is no, you do not have to use hormone therapy. Let's just delve into that a bit more and unpack that. Okay, so hormone therapy is looking at replacing the estrogen that you are no longer secreting as efficiently on the same amounts, is replenishing that. And we know now that estrogen cannot function well without progesterone. So I made this analogy earlier, but I think it resonates with a lot of women that estrogen is your fertilizer hormone. It makes everything grow. It makes things lush and plump. It's definitely a promoting hormone. And then progesterone is a calming hormone. It's literally the lawnmower that comes and cuts things down. So hormone replacement therapy now is really looking at more of a combination therapy, especially if you do still have your uterus, to make sure that we are getting the best of both worlds and really optimizing your functioning. So that's hormone replacement therapy, and we can further subdivide that into systemic. So if your symptoms are more global, if you are getting hot flashes throughout the body, if you have brain fog, if you are just feeling very anxious or very depressed, so it's affecting your entire being, then we would probably describe oral hormones or estrogen. We can also use patches. Those have also shown great results. And then if we have more local symptoms into the pelvis, then we can have a local application of these hormones into the vagina. And then we're not getting the systemic benefits of that. So that's hormone therapy, systemic and local. And then on the other side of that, we look at lifestyle.
Before you start with lifestyle, because that was the next question. So are there risks to hormone therapy?
Mm-hmm.
What is the risk to hormone therapy? So you
Yes.
quickly say, why do we not automatically put everyone
Okay.
when they reach 40 years old on hormone therapy?
So the risks with hormone therapy have a lot to do with blood clotting. So we have an increased risk of stroke, of deep vein thrombosis, and pulmonary embolism, which is just essentially a clot in your lungs. And these are fairly big risk factors. We also have found that there is a risk for increased risk for gallstone formation, and then also endometrial cancer. The more we study this, because there's definitely an upswing again in figuring out is this a good idea for women, is that these risks start really showing up if we start hormone replacement therapy a decade after menopause has actually started. So if you are interested in hormone therapy, the closer to age 50 that we can get you on, the better. The more the benefits of it. The older we get, we start finding that the risks actually outweigh the benefits. And so
it's important to understand that, because I feel often, I know I mentioned that when my mom went through menopause, I just said, come off this hormone replacement therapy. And because of the studies, but you really have to look at it in perspective. And that is why if we do put someone on hormone replacement therapy, we reassess after 5 years.
yes.
We say, what is your risk, your benefit? If you're a smoker, I won't put you on estrogen, because that significantly increases your risk for blood clots. But then if you get to a point where you say, I'm going to jump off this cliff if you don't give me estrogen replacement now, I'll say, okay, yes, now the benefit is definitely going to outweigh the risk, but you have to stop smoking.
Absolutely.
I won't give you, but so we look at everyone. Who are you? What's your genetic risk? What does your cholesterol look like? What is your health history? We do it with menopause. We don't, as in the studies, give it to people at 90 years. We give it at the time when you're going through menopause. Then you get maximum benefit for your heart, for your bone density. So that's quite important. And you mentioned everything, and the endometrial cancer as well. That is why if we do give estrogen, we give a little bit progesterone as well to protect your uterus, because you said it's a fertilizer. So if we just give estrogen, and that uterus will just get thicker. Yes, you're at increased risk of getting cancer. So what we do is we balance it with progesterone.
Exactly.
So that's it. Even if patients tell me they don't want a pill, they want an estrogen cream patch or a cream, and it's not the estrogen cream we put in the vagina, it's a different estrogen cream that's absorbed systemically, but you put it on any thin skin like your thighs. I'll give an oral progesterone that second half of the period to kind of mimic your cycle. If women tell me I really don't want to be on my period anymore, I'll give the progesterone every day, not 2 weeks on, 2 weeks off.
Yes.
To
yes.
protect your uterus.
Absolutely. And there's also talk now of maybe even getting ultrasound scans.
Yes, every year. I do it for my patients on therapy every year.
Endometrium. Just let's keep an eye on that lining thickening, and what is the cell quality like. So yes, there's definitely ways out there to make sure that the dose we give you suits your body and actually has a desired effect. So we definitely want the lowest dose for the shortest amount of time. That is sort of the healthcare motto. That's what the North American Society for Menopausal Health is all about. Shortest time, lowest dose. Let's see how we go. Rather than
and we reassess it. We don't just refill a prescription back to the
Exactly.
pharmacy. No, we reassess. I'll bring you in, go through your symptoms, understand what are you coping with. Because maybe initially your symptoms were such that you needed systemic therapy, but maybe at this point we can just treat your hot flushes with, it's a type of a blood pressure medication that we use if it's only hot flushes. We use herbs and lifestyle. So that's a big thing. That's why I opened my wellness clinic, to help people, guide you through if you decide you want to go natural, but you need a doctor to hold your hand. Lifestyle. That's my thing, lifestyle. So let's talk about that.
Yes. So in functional medicine, we look at sort of cornerstones of lifestyle. So we look at sleep, we look at nutrition, we look at movement, we look at your social support structure and what that looks like. And then...
which is a big thing, which I didn't really recognize before I went into wellness. And now also that we have gone through COVID, and because everyone did have some type of support structure. You would go to work, you'll meet other parents at hockey practice, You had your book club every week, you had your Bible study group, people had people. And only now that we went through a period very strictly in Canada where we did not have any social connection for a very long time, more studies have been done showing how important our community was. So that is, yes, that's really something I didn't realize was a pillar of health, is your community. And it would be good for you to recognize that. So when you do go and see a lifestyle doctor, and when you look at your own life, you're going to look at your food, you're going to look at everything, but you can continue. But please look at that. It's a big thing because people, it slip off people's tongues so easily. But I didn't understand that before I read all the studies that was done that showed that is going to predict how long you're going to live, how healthy you're going to be, what your risk is of dying of a heart attack. They've done these big studies where they, for example, they looked at a big group of nurses with breast cancer. And then they found that the group of nurses who had 10 or more friends were more and lived longer. They were less likely to die from breast cancer during that 10 years that they followed them than the group of people who were socially isolated. They did a big study with heart health. People who were socially isolated were more likely to die from a heart attack. It was the second biggest risk factor after smoking. So smoking was your biggest risk of dying from a heart attack. And then your second risk factor, bigger than your risk of cholesterol, diabetes, blood pressure, everything that I know to treat, was social isolation. So I encourage you, ladies, find yourself a tribe, a group, other women that goes through what you're going through at the same stage and connect with them. Find the group online, a support menopause group. It's critical to go through this.
Yes, and I'm going to add one other thing. Choose wisely. I wanted to do this in the last podcast, but I'm going to read this quote by Oprah Winfrey. And she says, so many women I've talked to see menopause as a blessing. She said in her own magazine in 2019, I've discovered that this is your moment to reinvent yourself after years of focusing on the needs of everyone else.
Oh, and that's beautiful. That's so profound.
And so I say choose wisely because for a lot of women, it's the myths around it is I'm going to get fat, bitchy, and irritable. And I don't want to be that. So we don't talk about it because we don't want to be seen that way by society. And we live in North America, most of us. It's youth obsessed, this culture. We don't want to see women aging. And now we have Jennifer Lopez and Nicole Kidman and Penelope Cruz and Julia Roberts and all these famous stars and actors hitting menopause and transitioning past it, and they still look fabulous. They are perceived as sexy. Jennifer Aniston is another one. Let those women be your inspiration. We're going to be living post-menopausally, arguably as long as we've been fertile. And so if we can just surround ourselves with women who inspire us and who bring health to the table and wellness, then that is the tribe to connect with. I've had some really bitchy, where it's a negative, it's a bit of a pity party. And I want to really change the narrative and go, no, this can be a moment to reinvent yourself, to relook at what works for you. What boundaries do you need to set? What relationships do you want to nurture? Let's thrive through this.
Because they say that you become like the 5 people that you spend most of your time with. And then even if you feel that you have a very strong internal locus of control, you're not going to be influenced by people. If you are with people complaining all the time, you are going to be more negative. So be intentional. That's why it helps to really, and you spoke about an app to track your menopausal symptoms. I personally like journaling. But you can put it on that app. There's always a place where you have your menopausal symptoms where you can write things and really reflect what makes me happy and what and who sucks the life out of me.
Yes.
Then you start avoiding those people who suck the life out of you. If it's a family member, you can, it's not a kid, but if it's a more distant family member, you can be more cognizant of that and restrict the time you spend.
Yes.
You don't have to call that family member every day who has a miserable life because you're their only lifeline. That we call that codependence. You're just enabling them to have a miserable life if you're the shoulder to cry on every day. So to really be intentional every day when you go and write down your menopausal symptoms, when you write down also write, even if you don't have the energy to write, just give your day a number. Is it a 10 out of 10, an awesome day? Or is it like a 0 out of 10? I can't live this way. And then if it's a 0, please go look for help right away. Stop watching it right away and seek help. We want to improve your quality of life, but if you need help, seek a counselor. Yeah. Critical, if you're in an unsafe relationship, seek help if you're important. But then, if you recognize, is it the 5 or 6 after a family gathering or after you've been to the girls at book club and you come home that night and you have a 4, then don't go to book club anymore. If you at work and you come back at 3 every day, maybe you must look for a new department. Maybe you must transition to a different team. Just be cognizant of what gives you energy, because you really know at a phase of your life where you don't have to please people around you anymore. You really know, you have that wisdom, you have that maturity, you're at your peak. You're now gonna do what is smart for yourself. It's hopefully your kids are grown enough that it's not just about them anymore. But then even if it is at a phase, where it's still about your kids, you're going to be more intentional, more mindful, because the better mom you are, the better you are, the better mom you can be. You can be better for everyone around you. I'm digressing. We're still at non-hormonal therapies for menopause. That was the question, and a couple of questions like that I try to group together about the non-hormonal therapies, just because that's such a big part of what we do. And you were talking about the corners. So we look at anything is better with better lifestyle. So one of the things that we really look at is your diet.
Yes.
Your diet is critical. Your happy hormones get made in your gut. Your gut, we call it your microbiome, consists of so many bacteria. If you do something like you've been maybe on birth control for a period of time, or you've been on antibiotics, all these things really disrupt your gut bacteria. The foods that we eat disrupt our gut bacteria. Any processed foods, any toxins, chemicals, pesticides on veggies, all of these things can be very harmful for our gut. So that's the first thing we look at is diet. Right?
Absolutely, and we want it to be anti-inflammatory.
That's big.
And so I know there's a lot of dietary advice out there around keto and fasting and paleo and what have you. According to the research and the studies, a Mediterranean style diet seems to tick all the boxes for longevity and health. I'm not talking crash diets and fads. So lots of nuts, seeds, oily fish, fruit and vegetables in season, a certain amount of lean protein, and then lots of grains. So
and that's a big thing.
Because
irrespective of what diet, if someone comes to me and they're on a vegan diet or they do eat meat, but is it a healthy diet? So we look at processed.
Yes.
The food that you see, is it the way that it walked around on a farm, or is it made in a factory? Because we were vegan for a bit, and I used to think that vegan is very healthy, but now I see a lot of my clients who are vegan, but they just easy. I'm not judging it at all, but it is easier to eat foods that you buy at a shop that comes out of a box, but then as soon as it has hydrogenated oils, as if it's manufactured, processed in a factory, you lose all those health benefits. So it's quite critical now that you go through menopause, make sure everything that you put in your mouth, is this building me up or is this breaking me down? You're gonna have cravings because you're gonna have some micronutrient deficiencies as you go through this. But then to think, when you have that craving, am I really craving chocolate, or am I maybe craving calcium, magnesium? What is it? And to replace those things.
Yes, in that time, absolutely.
So that's a whole food diet, and I push, when we do work out a diet for someone, we really look at your mitochondrial health. How do we support your mitochondrial health? How do you get, the easiest take home is to make sure that you add veggies to all your meals and protein to all your meals, whether you're plant-based or not. Make sure you don't just eat things out of a box, but you add veggies and you add protein to all your meals, and that you eat.
Yes.
That's such a big thing. So intermittent fasting is good for a lot of people, but when your body is going through a stressful period, yes, it's not ideal for perimenopause. And we can help you to get boost your metabolism, and you're going to do that by exercise. So let's get back to, because that's the next thing is what exercise.
Exactly,
yes.
Exercise. So they've looked at exercise, and we want to really make sure that we counterbalance these symptoms of menopause that are detracting from our exercise capacity. So prolonged cardio doesn't seem to really tick the boxes anymore as we transition through perimenopause,
which is
and
hard
beyond.
for us. Both of us are marathon runners. I've ran ultra marathons,
Yes.
so we are passionate about running. We're not against endurance events, but just looking at the research, seeing our patients, that is not the best for your body, unfortunately.
Exactly. And so where the science has landed now is that it's sort of a combination approach of definitely less is more. So resistance training, and that means really heavy lifting. So you are only looking at 3 to 5 reps of pretty much a maximum weight that you can lift. And your squats and your deadlifts and your shoulder presses really target all the muscle groups arguably in your body. So you've got 3 exercises, and that's a lot of bang for your buck. And then your short,
It's good. Maybe we should
high
pause here.
intensity stuff.
Yes. I just maybe want to pause there. So ideally, you can work with a personal trainer. That's fantastic. If you can get a personal trainer who's familiar with menopause, that's awesome. Most of us don't have access to personal trainers. If you don't, next one is you can look at someone reputable on YouTube and do exercises yourself. But what I teach my patients are those things that you said now, and to really maybe pause here and to practically for you, what you can do is squats. And the way you're going to do squats is you're going to stand against the wall, and you're going to sit as if you want to sit on the toilet, and then you're going to stand up again, and you're going to sit, and this is, you're going to keep your back against the wall. And every time you go to the washroom, you can think about that, is that because you want to, when you're older, you want to be able to get up. You don't want to have to press to push yourself up. If you already notice that when you get up on a chair, you have to push yourself up, or you're sitting on you prefer a chair. Even for my waiting room, we now look at different chairs. I want beautiful, fashionable, beautiful chairs that doesn't have an armrest, but the majority of people do need that armrest to push themselves up. We don't want you to do that. We want you to make your legs stronger. The way you're going to do that is by squats. So every time you go and sit on the toilet, remember that, and go and sit and up 10 times before you sit. It's going to, in the morning when you get up, you can do squats against your wall with a straight back. Squats. Next thing is that you say to be able to press heavy weights. What you can do easiest is to do a plank exercise. That's the easiest way to start. When you're strong enough for plank, it is ideal if you can hang your own body weight at a bar and then do pull-ups at your own weight. So that is even if you don't have access to weights, if you can just in your local park. I do it all the time when my kids do monkey bar. I just go and hang there and pull myself up. And maybe the first day you're just gonna hang.
Yeah.
And then as you get used to hanging your own weight, then you'll start to be able to pull up. And I think our goal, I must look back, but I think our goal at this age is to be able to pull your own body weight up 10 times, which is quite a lot. I'm very, very strong and I can't do that. So it is, but that's what's going to be the game. And you spoke about 3 exercises. It was the squats, your arms,
And the deadlift.
Oh yeah.
To get the posterior chain.
Yeah.
So up through the backs, because isn't this very common posture?
Yeah.
And so the ability to pull back, especially the muscles between your shoulder blades, to strengthen all the muscles supporting your spine, so that we don't fall into this sort of pattern with the dowager's hump. And that's because that increases, if you have osteopenia and osteoporosis, those fracture lines are often along where there's a lot of strain on one single vertebra, and that's the dowager's hump, and then also along the thoracic spine. So lifting heavy.
I see that commonly for patients that I've met to hospital, would be these compression fractures in your back. But then also you won't get those compression fractures if your bones are strong. And we look at bones for calcium. We now know we don't need milk for calcium. The big studies where they found that people in, say, Finland, where they consume the most calcium, the people have most osteoporosis. And then more Asian countries where they don't consume any milk, they have least osteoporosis. So we now know that myth. We don't need milk for our calcium, but make sure that you do get enough calcium from your diet. If you looked at your diet and you really know you're not getting, make sure you take a calcium supplement with a vitamin D supplement. Vitamin D helps to absorb, to make your bones thick. But then to get those bones strong, the way bones get strong is by that little bit of traction continuously that we do with weight exercises. And that is why it's important to do these squats, to do these back exercises, to also get where the muscle implant into the bones to get that strong.
And they've done studies on osteoporosis and found that 2 sets, one in the morning, one in the evening, of 10 jumps a day, so literally just jumping up and landing on your heels, improve bone density throughout the whole body.
That's incredible. See, that's something else you can do for free.
Jumping. So jumping, we want to jump less as we get older, fear of falling, etc. But it's counterintuitive and it's counter effective, really. So jumping, 10 in the morning, 10 in the evening, and that is a very big.
Well, I'm going to start jumping.
Absolutely. So plyometrics, that's another thing. So high intensity cardio, short bursts. Heavy weightlifting, yoga, or any other flexibility exercises,
Stretching.
because we tend to stiffen up as we get older. And then your plyometrics, so sudden high impact landing, really great for bone density.
Nice, thanks for that.
Cool.
Next question is talking about prescription medication. And we've gone through it so much when we did our full episode. I think you covered, because they ask a lot of things about prescription. They ask, should I take the estrogen cream, gel, pill? And that is so specific. That is something that we can't really answer on a talk show like this, because it's going to be different for each and every one. You'll have to see your primary care provider, look at your risk factors, look at your symptoms, look how you're responding to things. And there isn't a right and a wrong. And I feel so sad when certain therapies get villainized. So people will sometimes say, oh, I want these symptoms treated, but I just don't want those medication because it's so horrible. And I don't, but to always keep things in context, to see who are you, what are your symptoms. That was something that I actually found very hard through having babies and through breastfeeding, because people say, oh, this is right and that is wrong, but it doesn't take in context that I'm a family physician who's, even though I have my own baby, I have to deliver babies at night. I don't have the ability to pump all the time. I don't have my baby with me to breastfeed. I think there is a lot of things that you must really see in your context. What does your workday look like? Maybe your sister did breeze through her menopause just with a fan because she was sitting at home and no one cared that she had to change her clothes 10 times a day. At work, it is harder to change your clothes 10 times a day because you're wet and drenched in sweat, so it's so tailored. One of the questions is specifically about, I've never been depressed. My doctor wants me to go on antidepressants now. If you are depressed, you need help. We can't really tell you what help you need. I have some patients who go on antidepressants and they do fantastic on it. They don't have to stay on it for life. They would likely just have to go on it through their perimenopausal phase. It does not mean, I had a patient yesterday who told me that when she was going through burnout, her doctor didn't understand burnout. He just gave it an antidepressant. She didn't do well on it. Of course not, because she wasn't depressed, she had burnout. But it was because of that thing 10 years ago that now she won't take antidepressants. So for me, it's always important not to have that black and white thinking. You are on a spectrum, your situation changed.
And remember, these are not drugs that we're prescribing for the rest of your life.
Yeah.
Often they are
just
to
help you.
Exactly. They are for a moment in time. They are to allow you to get through the next 6 months, and then you reassess. And so I think having a good relationship with your healthcare provider, and that there is a bit of give and take, and that these things are adjustable, and that it's not a one-size-fits-all solution. That can be really, just inspiring for a lot of women, that this is just a means to an end. This is not a sentence for them. This is not the status quo for the rest of time.
And what you mentioned about tracking your symptoms, that's on antidepressants. If I ever put a patient on antidepressants, I always insist that they journal. And for people who don't journal, I'll say, just write a number. I'll send them home with just a little printed out calendar and just write a number for every day. Because what sometimes can happen is people come in desperate, they need something. And I always first push lifestyle. So I say, okay, no, wait, before you can have antidepressants, you first need to look at your diet, your sleep, your relationships, who boosts you. And they're like, I'm going to jump off a cliff if you don't give this to me now. Then I say, okay, but what is your number today? And when you start taking this medication, journal or just write a number for every day. And then if people get better now, their numbers are 3, 4, 3, 4, and they get better. And then their numbers are 7, 8, 7, 8. They might come back after 6 months and tell me, oh, this medication doesn't do anything. I don't need it. I want to stop it. Then I always say stop. It is always, always better to not use any medication if you don't need it. Yeah. Because there isn't such a thing as a medication without side effects. Even the herbs, botanicals, adaptogens, everything I prescribe, we just use it to treat something. If there's not something, we don't treat it. But then what often happens is when they stop their medication, then the numbers start dropping again. Drop. And then, so it just helps you to more objectively see,
absolutely,
did it help? Because we are so subjective, it's so hard. If we have a good day at work, life is good. When we have a horrible day, life is horrible. So it helps you. And I don't really decide ever for people if they must take medication or not. It's something you decide on your own. But just journaling will help you to more objectively see, do you need it? Are you benefiting? Are you benefiting enough? So I hope that answered your question on antidepressants. One thing we often prescribe is Venla vaccine, because that specifically has been studied for women during menopause, helping with menopausal mood, improving sleep, and also specifically helping with vasomotor, hot flushes. Clonidine is something that we give if it's only hot flushes, if it's not related to, if there's just the vasomotor symptoms, no other symptoms. And then, lots of questions about medications that you're going to chat with your doctor about, your specific. So what are the long-term risks associated with menopause?
Right, so we have identified estrogen as being heart protective, bone protective, brain protective, and
so it protects you against certain types of dementia, vascular dementia,
cancer,
it protects you against
osteoporosis and osteopenia.
Yes.
And so the long-term effects then are the flip side of that. So osteoporosis is your big one, and then your cardiovascular risk factors, so stroke and heart attacks, heart disease, and that all has to do with what estrogen does. So estrogen is an anabolic hormone, which means it promotes growth, like I said, the fertilizer hormone. So it promotes bone turnover and promotion of bone density and growth. And so when we have lower levels of estrogen, that turns more catabolic, which is the breakdown process. And then we are at an increased risk for osteopenia, which is just low bone density, and osteoporosis, which then becomes more problematic and can lead to fractures. And then cardiovascular wise, stroke and heart attacks, because estrogen helps keep the arteries, the blood vessels, nice and soft, pliable and soft, and it responds well to sort of changes in blood pressure and movement. And as the arteries thicken and harden, there's more plaque deposits, and that is a precursor of cardiovascular disease. And then we also find that a lot of women will say they get very dizzy when they stand up quickly. And so this change, when the blood pressure changes as you get up quickly, because the arteries can't...
They're more stiff. It's like a macaroni. That's more, that got old. It's stiff and not soft.
So it's less pliable, and so it can't adjust to these sudden pressure changes as well, and then you get this lightheaded.
Because you need a higher blood pressure to pump blood all the way to your brain when you're standing than when you're lying in bed.
Absolutely, and so it's a sudden change in posture that can drive these changes. So those are the two big ones.
Many questions on hot flushes.
Yes,
so it is very common. Some things, what can we do if we want to manage this naturally? What can we do about what triggers a hot flash question, and how do we navigate through it?
Okay, so identifying what comes before your hot flash can be really helpful. So is it intake of caffeine, alcohol, spicy food? So again, let's look at diet. Then what is your if we're talking night sweats, what is your bedroom setup like?
Yeah.
How try and keep the room as cool as possible. Use fans if needed. Have layers. Have lots of cotton, lots of natural fibers rather than synthetic. Exactly. And really, for exercise, a lot of women find that they start getting hot flashes while exercising. Pre-hydrate with ice cold water to really keep your core temperature really low, and then there's less of that response to start a hot flash.
That is very smart. So I didn't know about this, and then when I was doing, because I do triathlon, and I would see people at Kona, which is the Ironman World Championships in Hawaii, they will race with like these things in their clothes, and I had like no idea what was wrong with these people. And then when I was doing the Ironman Muskoka, suddenly while I was running, and someone asked me alongside the road, would you like ice? The penny just dropped. They have like ice packs. So I put ice in my bra. Like I was just like pouring, and this wasn't even ice packs. It was just like ice to drink. I was like, I said, yes, I want ice. I was just like pouring it into my running bra. And it makes such a big difference. And then if I looked at my race time afterwards, my heart rate didn't even go significantly up. So my whole body was just like cool and calm. So it was hot. Everyone, it was very hot day in Muskoka. Running, everyone was hot and tired. But just that having that ice on my heart had my heart rate cool and calm the whole time.
And your thermoregulation center actually sits in your hypothalamus, so it's right at the back of your near the brainstem. So if you put something cool along the back of your neck while exercising, your body picks that up as sort of its main heat control center. So if that is feeling cool, it finds that there's less necessity for these hot flashes, because it's a thermoregulation abnormality that happens. Again, lowered estrogen keeps the thermostat going a bit more wonky, so the body tends to overreact to stimuli. It notices possibly a small change in your body temperature, because remember, your core doesn't want to get above 40 degrees. That's life-threatening. And so a small change, and it overreacts. It wants to get rid of the heat, and you have this massive vasodilation at your extremities. You sweat profusely, and then your body goes, oh, sorry, my bad. That wasn't actually necessary.
So what you will do practically, when you feel a hot flash, you'll have your fan, you'll have your cold pack that you're going to put on your neck, and you're going to breathe through this. So you're going to do your deep breathing exercises. You're going to stimulate your parasympathetic nervous system by stimulating your vagus nerve. That's going to tell your body this is okay. This is okay. Even though you don't feel okay, you're going to teach yourself how to teach your body that this is okay, and that will help your hot flashes to be less intense and shorter.
Yes.
Okay, and you can still have, some of my patients have 10 of them a day. We don't want to minimize the severity. We just want to help you, guide you through it. Next question. Can menopause cause facial hair growth?
Okay, so menopause means fluctuating hormones. So relatively speaking, if estrogen and progesterone are relatively high, we can have a period of higher testosterone growth, and testosterone is related to facial hair growth. So yes, we can. So pluck, wax, whatever you need to do, girls, to get rid of that.
And then is having a hard time, oh yes, that's a big one, brain fog. So the question is about concentrating and memory and things like that, but let's talk about concentration, being forgetful, brain fog.
Okay, good news is it's typically transient. It hasn't found to be a...
just because you now have memory impairment lapses,
that is going to be for the rest of your life.
It's
exactly, it's transient. Okay, and it's through menopause. And it's more related to progesterone declining, because progesterone is very calming to the brain. It helps us focus and jogs our memory. And so when progesterone is doing this, then we have the brain fog, the fuzziness, the loss of concentration, irritability. So it's more the brainy kind of symptoms are related to progesterone. But the good news is that as estrogen and progesterone both level off at significantly low levels post-menopausal, our cognition, our memory function gets back up to speed, and we have a memory as good as we did before.
So that's quite helpful to know that it's a phase. And I think that's a lot of anxiety about this is, oh my goodness, am I aging? Is this the new me? So that takes a lot of anxiety away. It does help to journal, because people will say that I don't remember anything. So, and journaling helps you to be objective, to be intentional, to know it's not that I'm forgetting everything. I was in that specific meeting and I blanked when I had to present to the board about ABC. I blanked, but that was in isolation. I could drive back home and cook dinner, and there wasn't any other memory lapses. So to really write those in, it really just helps.
Yeah.
If you just intentional about everything you do, it helps to take a lot of drama and anxiety out of it.
Absolutely. And then we know that cognition we can boost it by doing crossword puzzles.
Yes.
Learning a new skill, learning a new language has been found that we can do that as well as any 20 or 30 year old. And avoiding sort of the passive activities of
Netflix watching, scrolling for hours on your screen.
But yes, so that's an option that we have.
Yeah, and that's quite a big one, and something that we, both of us who do lifestyle medicine, really encourage our clients to go out, to go walk through trees, to get ecotherapy, to go, because most of the passive things are not good for your brain. It's been shown that your concentration, all these things improve when you are outdoors. So to be cognizant of that.
It helps us speaking. Yes, it does. We need to go outside soon.
Yes, but yes, get back on TV and then also exercise. So when you are getting out, getting your ecotherapy, go for the walk, combine 2 in 1. It brings us to the next thing, that a couple of questions regarding moodiness, anxiety, depression. I kind of coupled these questions together. I think we want to go back to saying that if you are depressed, get help.
Mm-hmm.
Watching our YouTube videos not going to cure depression. Get help. There's a lot of things that you can do. If you do get help and your psychiatrist prescribes an antidepressant, yes, there's still so many things that you can do. Most of your happy hormones get secreted by your gut. Things can make you more anxious. If you are always in flight or fight response, because you're secreting cortisol, because you're stressed out, the way you're going to counter your anxiety, counter being stressed out, is by what you eat. It is by stimulating your parasympathetic nervous system. There's so much. I don't know if you want to add to that. There's resources on my website. You can have a look at wellnessmdhealth.com about breathing exercises, about healthy, eating healthy, doing things to counter your stress response.
Yeah, I think one of the fun things I give my clients is, what do you do for yourself? I ask them, what brings you joy? And I see a lot of moms, and there's a panicked and then a blank look, and they're like, what do you mean? I said, no, what do you do in your day for you? And most of us women can't answer that question confidently, or if we can, we do it once a month. And so that's often, I'm like, that's the homework I'm going to start you off, because when we do activities that bring us joy, we find that incredibly calming. And so rather than another to-do list, because frickin' hell, we've got enough on our chore chart, doing something that brings joy, wow, like you want to do it. There's an impetus there, and then it calms you, it clears your brain, it puts things into perspective. So it actually has a whole bunch of side effects really from one activity that can really change the perception you have around your day and what you are doing. So that's a homework I give a lot of my clients is.
And that's very smart, because it's different for different people.
Mm-hmm.
And then even for me, I enjoy running. That gives me joy. But now that I am running and I am competing, now I have to follow a certain program to be able to compete at a certain level. And now it sucks all the joy out of it, and it makes it a work for me. So when I plan my year, when I plan my month, I say, oh, I want to run, I want to swim, I want to bike, because it gives me joy, it makes me happy, it balances my hormone, I want to do it. But then when I do set my alarm for 5 o'clock every morning to go train, it does suck the joy out of it. So to be very intentional, and the fact that your activity, that book club, did give you a lot of joy when you joined a year ago. Now it's not giving you as much joy, because everyone is just drinking wine, and you're cutting back on wine because of your menopausal symptoms. Then you're going to stop that, because you're not doing it to please everyone else at book club. You're looking at what you need at this phase in your life. And it doesn't mean that you're not going to rejoin your book club next year. It's just where you are now. So that's a big one. Jumping to the next topic, headaches.
Okay.
Headaches is a big one.
Headaches, and difficult to really always bring back to menopause if they are, okay, first of all, if they are very, very bad and very different to what you're accustomed to, seek medical help.
You'll go to Emerge, don't email us, 911.
Yeah, that's
It could be
enough
a
calls.
stroke.
Exactly. Headaches, multifactorial. There are so many reasons you could be having headaches. Yes, there is a link to hormones. We're not quite sure what it is, but if you have suffered from migraines around your premenstrual PMSy things, then you might be more susceptible to hormones in your perimenopausal phase 2.
Next topic we had a couple of questions about was vaginal dryness, and I don't want us to go through things we've already discussed in the initial podcast, because we spoke extensively about vaginal dryness, saying that it's not just about painful sex.
Yeah.
It's also that if you have less estrogen, and you mentioned that you're more plump with estrogen, your vaginal skin will get thinner because it's thinner. Oh, and also because of less estrogen, your pH change.
Yes.
But then it's also thinner. So the pH change, you can just on wiping get bacteria. That's the bacteria I most commonly get when my patients have urinary tract infections. We always culture before we just treat. We culture to see what type of infection there is. Then we tailor the treatment according to that bacteria. It's most typical bacteria that are on the skin or around the anus, normal bacteria that should be there. But now because of this thin vaginal wall, it got into the bladder. So it's not about being dirty. It's just about your skin being thinner, pH change. So the bacteria can cling to the wall easier, causing an infection. So vaginal dryness must be treated.
Yes.
We want to have that vaginal wall thicker. There are over-the-counter products we can buy.
Absolutely. So we can, hyaluronic acid is in a lot of high-end face creams, and you can also get preparations in forms of vaginal moisturizers that you apply every night to the vaginal entrance and also into the vaginal canal. Hyaluronic acid, and then there's also local estrogen suppositories, gels and creams that we can apply that have a similar function that just help
thicken the skin
thicken,
a little bit.
exactly.
Your body don't absorb it. It's just targeting
Local.
that area.
Yes.
Yes. And that brings us after the vagina to the bladder. And how does menopause affect my bladder? There was questions about urinary incontinence, and we did answer that already. And that's your speciality as a pelvic physiotherapist. Is there is a lot we can do.
Yes.
And I'm gonna, just to make it quicker, say to go and look at your website.
Perfect.
Yes.
Great. Yes.
Because that is a big thing. You can do a lot of things. There are exercises you can do to help with bladder control. Will you just maybe quickly run through the types of incontinence that you get?
So we have stress urinary incontinence, which is literally a loss of urine in response to a stress. And by stress, I mean an impact. So not because you are feeling stressed. So it's a jump, a cough, a sneeze.
You just told people to jump 10 times in the morning. So if you start doing it and you jump,
and then you leak, you come and see me.
urine.
Okay, so that's stress urinary incontinence. Then you have urinary urge incontinence, which is you are feeling the urge to go, but your bladder overrides the pelvic floor and you start leaking as you're unbuttoning or as you are about to approach the washroom. So that's urge incontinence. And then
Painful.
we have
No, that's not incontinence. You have painful urination.
Exactly. So painful urination has a lot of factors to it. So we need to dive into that because it can be a symptom of a urinary tract infection.
And you might also need an exam, because sometimes
Absolutely.
people will say that painful urination. I first say, let's test, you might have an infection. Then they don't have an infection. Then I really need to go and have a look. Because maybe there's a little bit of yeast, but the yeast excoriated the urethra to such a degree that it's painful every time urine pass, or your skin is just so thin from estrogen deficiency. So you will need an exam at a certain point to see what's happening there.
Absolutely.
And then we have nocturia as well, where people need to get up at night. We see it in males all the time with larger prostates.
Yeah. So nocturia, we no longer sort of pathologize if it's only once a night. I think it gets more problematic if it's a 2 or 3 times a night, because your bladder should be able to hold the night volume of fluid that the body's creating. And we just want to make sure that women are not going just in case, because that's most of us. We pee just in case because of the social stigma attached to peeing in public. Boys can pee behind a tree and typically no one bats an eyelid. It's a bit different for girls. There's a lot more social stuff happening with females voiding. So going at night just in case, we really want to nip that in the bud, because the bladder has a tendency to become overactive then. And then we're dealing with a whole bunch of other factors. So nocturia is something I have a discussion about, but it's not here to
And patients find it very upsetting if you woke 5 times for hot flashes or night sweats, and now you woke as well for having to go to the washroom. That really impairs your quality of sleep, right? So it is a big deal when you...
Absolutely.
So this is a very valid question. Okay. This question was talking a bit about hot flashes, but my hot flashes aren't as intense as the ones my friends describe. Is this normal?
Yes. Celebrate. Enjoy the fact that your hot flashes are not as bad. Honestly, it's every woman's symptoms are different. I would also suggest that you speak to your friend and maybe have a check-in with her GP about checking in with her cardiovascular function, because there have been correlations to the severity and of your hot flashes and cardiovascular events later in life. So if you know of someone who's really battling with them, get her to have a physical, find out what's happening with her heart and her arteries.
Yes. And then it gets me, so I am having severe hot flashes. I do not want hormone replacement therapy. What can I do?
Okay, then we go through the whole thing of diet, what triggers them, the bedroom setup, the cooling, making sure that you are dressed in layers, natural fibers, and then the whole bit about even taking something really cold, an ice pack, even to bed with you, or putting a cold face cloth across your back of your neck. Exercise.
But then if they have lifestyle perfect to the T, what do we give? So there's some over-the-counter things we do, right? Sometimes vitamins, supplements, ibuprofen.
Yes, I'm not as well versed in those
products.
In terms of like prescribing those. So
there are options.
Fantastic.
There are definitely options.
Speak to your GP.
And then those would be typically, if you're looking just for it yourself, if your GP doesn't know well about it, black cohosh does help to reduce your sweats. If it's more at night, having some melatonin and valerian root helps to improve your quality of sleep. Will I start menopause if I have a hysterectomy? This specific question didn't say anything more about it, and you'll have to talk to your doctor. It depends whether they're going to take your ovaries out or not. If you depends why you're getting this hysterectomy. If because there is cancer in your uterus, they will likely take your ovaries out as well. We call that an oophorectomy. If you do not have cancer, then typically what we do here in Canada is to leave the ovaries, because it protects your heart, protects your bones, and then you will not go through menopause with the operation.
Exactly.
Can I get pregnant during menopause? And we did speak about that. Yes,
you can.
Then my skin is itchy and it has aged so much since becoming menopausal. What can I do about this aging skin? And I think you did address it. It's because of that collagen in your skin. That is exactly when you look at someone younger skin, that is more like plump, and as you get older, you have less elasticity in your skin thins, and that's often why it becomes more itchy.
Absolutely.
You must also then be more careful with the products you use. Please use the Yuka app, YUKA. Scan all your beauty products. You can look at the website EWG.org. It stands for Environmental Working Group.org. Has a list of safe beauty products. So you could have used beauty products your whole life, but that didn't bug you. But now that your skin is thinner, it's easier to go through the layers into your deeper layers of skin. Can be harmful. We always advise products that has no perfume, no color, really plain, clear petroleum jelly, Vaseline, to focus on those things for moisturizing. Your soaps, even your laundry detergent can now cause itching, even if it did not cause itchiness before menopause. Libido, getting back to libido, ever since my period stopped, my desire for sex has decreased. Is this normal?
It's common. I don't like normalizing it because there are a lot of factors that play into libido.
And you can enjoy sex. We have many clients that's very happy with awesome sex life, so you can enjoy sex after menopause.
Also, fun fact.
Painful is not normal. If it's painful, see someone.
Absolutely, but your vagina performs or does better if you have regular sex or orgasms. So we're getting a lot of blood flow to the area. The vaginal tissue remains better moisturized. The vaginal opening doesn't sort of, for want of a word, close up or become very sensitive, the skin. So lots of sex throughout the lifespan.
And orgasms, and it doesn't have to be,
through penetrative intercourse, exactly. We can use vibrators and that kind of thing to also get.
Yes, you don't need a partner for that. You do your own thing.
Yes.
And then I think to end off is to say that menopause is amazing. It's really a deep spiritual phase. It's an awakening. When I went through puberty, my mom bought me a big bouquet of flowers and box of chocolates because I'm now becoming a woman. We have to celebrate that when we go through menopause. It's really it's a spiritual phase. It's awakening. You can rewire your brain. That's the most incredible thing with neuroplasticity.
Yes.
That you now have control. You can think, who do I want to be when I'm 80, when I'm 90 years old? You can be who you want to be. You are going to be who you make choices now that's going to determine who you are going to be at 80, 90. Are you going to be just miserable and grumpy, or are you going to be this person full of wisdom who's going to uplift the generation after you, who's making this world a better place? The power is so in your hands, and this is such a beautiful phase to go and look back. And I really love that quote by Oprah Winfrey. I think I'll put it in the description below. Thank you so much.
You're welcome.
For spending time with me.
It was fun.
We love to hear from our listeners. Please like and subscribe. Click the button to get notifications when I have another YouTube video coming out. Like and subscribe. You can follow me on social, LinkedIn, Facebook, Pinterest. I'm like, if it's social media, I'm on there. You can follow Gerda. We'll put our hashtags in the description below, all our links to follow us. And send us messages. You see that I answer all your questions for our next and there's, I'm going to talk about this more because I'm so passionate about normalizing this, educating people. I honestly feel we need the same curriculum that people have about puberty. We need this. We need more education out there. And we talk about this a lot, but I have patients from different cultures who tell me that, oh no, they didn't get menopause. It's a white person's problem. And I'm like, oh my friend, you're gonna get menopause. But then I'm their only way to talk about, the only person to talk about menopause, because in their culture, they don't talk about menopause with their mom, with family. They don't have that community. So I'm very passionate about normalizing it. People do go through it. And how do we make the best of it? How do we thrive through it? How do we go really with optimal health through it?
Thank you for joining us for Health and Wellness Talk with Dr. Daniela Steyn. Subscribe to our YouTube channel today. Connect with Dr. Steyn at www.danielasteyn.com. The content of this podcast is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your healthcare provider. Never disregard medical advice or delay seeking it because of something you have heard on this talk show. Remember, you were created to thrive.